Okay, Assalamualaikum. So welcome everyone. This is CME number 3 for cardiology, and today's topic is premature ventricular complex, a stepwise approach in diagnosis and management. And we have our presenter, Dr. Firdaus Zakaria, cardiology fellow from Uitm. The floor is yours. Bye-bye.
Ada macam online kan?
Okay. Share screen.
Boleh cek.
Plus 4 minutes also. CBMS. CBMS lapor rupiah
Ibu tak ikut. Tapi lebih depan berkontesi. Baca ke nak bagi NSC kan lopan. Kalau nak mungkin tak ada lagi. Nombor pizza. Tengok tak ada lagi yang tak. Oh siap kan?
Bismillahirrahmanirrahim. Okay. Assalamualaikum. Very good morning. My name is Firdaus. So I will talk on today's PVC topic. PVC stepwise approach and diagnosis of management of PVC. Alright. So let me share my slide first. Yang makcik semalam macam kena bawa balik yang macam yang ni tak ada malam tadi just balik aku buat NGO. Okay.
Itu dah buat juga
Tu nak kena apply tapi tak boleh bayar, tapi kena apply mengisi funding. So we start with presentation. So Assalamualaikum and welcome for Cardiology CME today. So I given the task to present on PVC stepwise approach in diagnosis and management. Okay, so first when we talk about PVC, first we need to know what is the mechanism of PVC, how localize the PVC, the guideline, PVC management, and when we want to refer for ablation for PVC. So as an introduction, the definition of PVC is a premature occurrence of the abnormal QRS complex, typically more than 120 millimeter second, correspond with the T wave typically broad and in opposite side of the major depression. So PVC mainly they originate from a ventricle, as you know, compared to PAC. So it's a normal, sometimes normal people will have PVC, as we studied before, about 1% detected in 12 ECG. When they did a study in American population, but when you do the 24 hours, about 40 to 75% of them have some form of PVC, but this one is just a benign PVC. So it's a common. It's a sometimes a normal physiology, normal physiology, but it's a sometimes when it's too much, it's become disease become malignant. So PVC prevalence increase with age, hypertension, and obesity. So there's a few mechanism of PVC. We have a re-entry, we have trigger automaticity. So re-entry normally is occur in the scar tissue when we have scar tissue in our heart. So there is a conduction cannot go to the scar tissue and it develop surrounding the slow and fast pathway. So it will sometimes it become when it depolarize, and then it can reduce, it can induce this PVC episode, and also triggered automaticity as well, one of the mechanism. So first of all, we need to know what is the location. We need to first identify the location of the PVC. So PVC location identification same is a VT itself. So we have a few, but this one is quite difficult. But we need to know that it's most common PVC is coming from the RBOT obstruction, about 70 to 80%, and others also LVOT. LVOT is about 50 to 25%, and also others area of PVC foci as well. So okay, so but how to localize? How the basic principle to localize the PVC first? From this heart, you know, when we have some electrical conduction, when the conduction travel from the AV, for example, for the SA to AV, if we have the positive deflection, okay, so when it go down, in the ECG we have positive deflection. So same as localization of the PVC. When the PVC, so first thing you know that we need to see. The first one is in a V1. This patient have a LBB or RBBB morphology. So as you know that RBB morphology, in one we have an pattern or material. So this patient, if patient have RBBB origin, as you can see that foci is from the right side. So right side travel to the left side. So the first want to detect when to localize the PVC is first we see the V1. So this patient have, if this patient have RBBB morphology, so the PVC is coming from the left side. If the patient have LBBB morphology, is patient have a form coming from the right side. And then the second thing is we need to see the inferior lid. So inferior lid, as you know, inferior lid when our axis is located at the inferior of the heart. So it's below. So in the apical here, okay. So as you can see, if the impulse is coming from transfer from apical to up septal, so we have the positive deflection. So for example, if in our inferior lid we have a positive R wave, or that mean there is a positive deflection. So that means our PVC is coming from the base to the up, from the apical to the base. So it's mean from the maybe this one RBOT or RBOT or LDOT. So if patient have a negative deflection, so that means our PVC is from the below to down lah. So it's from the electrical is from below to the apical. Okay, so that's how we localize the PVC. And then another thing we see in the septal in the one. So if in the one, if patient have the positive reflection is coming from the septal, but if ECG show that it's negative reflection is coming from the lateral or apical segment. So this how we want to first localize, identify the foci of PVC coming from where. So this one is easy, but there's others quite difficult method. This one is very easy, but you need but I think if this you just need to understand this. The other thing, there is another complex thing that is quite complicated. maybe if you want to do post-CV EP, and then you can learn more how to identify the exact location of the PVC. Because when we identify, this is important to identify because the certain location carries a good prognosis. For example, we have some good prognosis in terms of very successful treatment with medication, beta blocker, as well as successful rate of ablation in some form of location of PVC. For example, from RBOT is a good successful rate. It's also good treated with medication. Okay, so this is for example. From this first ECG, okay, so what do you guys think is coming from where? So first, like I mentioned, first we need to see the V1. So V1 is at the left bundle or right bundle morphology. So this one is okay. This one is Mero or left, Mero or William. Okay, so this one is LBB morphology. So it's LBB morphology. So most likely patient this PVC came in from the right ventricle. Okay, right ventricle. And then you can see and then again you see the inferior leads. So inferior leads are positive or negative. So it's positive. So that's mean from the apex to the up. Okay. So most likely this patient have some RPOT location of PVC lah. Okay. So yes, RPOT flow location.
From the top to below,
RPOT from atas. Okay, so top to below. Okay, so and then how about this one? You can see this one is RBB or LBBB. So V1 is like okay, this Mero pattern. So that means this RBBB. So RBB is for me came from the left side. So okay, against the inferior is up. So most likely from the atas ke bawah, so most likely the location is from the atas lah. So mungkin this patient have a LBOT or LBOT for kind of a PVC. Okay, so these are how the division. So you need to just know this because sometimes when you apply the PVC, it's important in terms of what management you want to offer this patient. Because if very like say if RBOT or this one LBOT is a good when think medically and also as well the ablation. Okay, so when we want to assess the PVC, first we need to know the symptom. So sometimes patient don't have any symptom, but you need to ask what symptom. Most common presentation or symptom is palpitation. Others is sometimes patient have syncope or pre-syncopal attack, so that's a symptom. So you need to explore more. Some patient have a chest discomfort, a chest pain, and also we need to ask regarding patient have any structural heart disease or not, because structural heart disease is important. It's a different kind of management, and then family history of sudden cardiac death, and also we need to look for any evidence of structural heart disease. Okay. Okay, so the test when we diagnose patient have PVC, always you need to do echo. Echo is the first initial management. It's important because we want to rule out any structural heart disease. For example, if patient have some reduce of ejection fraction, have some abnormal, for example, mitral valve prolapse. Some mitral valve prolapse is high risk to have a PVC as well. And also next you do Holter. Holter we can assess what is the PVC burden, and also Holter also we can see what type of PVC. The PVC is it monomorphic, polymorphic? So monomorphic means that PVC is same, just the same. That means this PVC came in from same location. If polymorphic, this PVC came in with multiple foci. So there's a case also the can prognostic this patient. If monomorphic or PVC, there's a good prognosis. So okay, and then Holter as well. You can see you can calculate what is the PVC burden from the Holter itself. Another thing, sometimes we do is exercise testing to test any evidence of some channelopathies or okay or structural problem. Okay, and also if patient have sometimes patient have PVC, elderly, high risk, and the PVC sometimes is like not like monomorphic or non-sustainability, so we need to allow ischemia. Ischemia is another thing that can cause PVC as well. So if patient has sometimes, we also do cardiac MRI if we suspect this PVC is associated with any evidence of structural heart disease that we cannot detect in the echo. We have any evidence of late colonial enhancement or evidence of ischemia. Okay, so for the guideline or for the management of PVC, I think the latest 2022 guideline 2 years ago published is quite helpful to guide us how want to tackle, how want to treat the PVC. So management is guided first based on the symptom. If patient have symptom, then you need to treat, of course. If patient asymptomatic, and then sometimes you don't need to treat, you just monitor. If patient and then the second one, we need to assess the PVC burden. What is the PVC burden? So the guidelines are quite different. So some use high PVC burden more than 15, some more than 20. But if the PVC more than 10, sometimes that's why you need to start worry lah. So you need to monitor, you need to start discussion on medication. And then of course the guideline also, we need to identify the location of the PVC itself, whether this one is like I mentioned just now, from the RVOT or LVOT or other parts of PVT. And also we can assess the morphology of PVC itself. Is it for monomorphic, just the same area, or polymorphic PVC, that is different area. So sometimes location can guide us or can guide the EP itself, whether they want to whether they want to possible for the difficulty management is for catheter ablation. And then need to diagnose patient have structural heart disease. So mandatory to do echo, to look for ejection fraction, to look for any wall abnormality, akinesia, or any valvular abnormality, in this case, and then that guide us for the management of PVC. Okay, so this EAC table show that is how want to output the PVC. Patient have PVC, we need to know the morphological, and then we need to ask the history, any cardiovascular risk, comorbidity, and patient medication, family history of sudden cardiac death. Okay, and then we can send also some laboratory like NT-proBNP, thyroid function test, and then we also have see what type of, when we see the halter itself, we can see what kind of PVC. Is it a non-sustained VT, soft couplet PVC, or polymorphic VT? If we can detect this, sometimes they need to be considered for admission for monitor. And if we detect PVC, of course, we need to do echocardiogram and also 24 hours halter. So echo we can, because we want to categorize this patient, whether normal structural heart disease or abnormal structural heart disease, and also 24-hour halter because we want to assess what is the PVC burden. So if the patient have normal structural heart disease, they define also the categorization is idiopathic PVC. So if idiopathic PVC, then you assess what is the PVC burden. If PVC burden less than 10, normally you don't need to worry. You can discharge the patient and then reassurance. And then if patient have PVC burdens of more than 10, so that's need to be for the further monitor. I will go to the other slide later. So if patient have any evidence of structural heart disease, so of course, first thing we need to know this patient need to allow any evidence of coronary heart disease, and also CMR is class 2 when we class 2A indication to do the cardiac MRI to detect any to detect any evidence of cardiomyopathy, or sometimes we can detect any scar VT from the MRI access. So okay. So another thing that we need to consider, sometimes we have some evidence of channelopathy also associated with the VVT, with the typical, with some ECG diagnostic as well. Okay. Okay, so this diagram show the management of idiopathic PVC. So it's idiopathic PVC, like I mentioned just now, we don't have, and there's a structural normal heart disease, don't have any evidence of structural abnormality from the echo. So we assess this patient. So there's class 2 indication to do possibly with the CMR, and then again we assess this patient. If patient have idiopathic PVC, we can, first thing we need to see the symptom, if patient have symptom or not. If patient don't have any symptom, and then we assess what is the PVC burden for this patient. If PVC burden less than 10, we can discharge this patient. If PVC burden more than 10, so this patient we need to follow up this patient we need to monitor the echo and to monitor the ejection pressure. If the PVC is more than 20%, so this patient also need to be monitor for ejection, monitor for ejection fraction, and also this patient have a class 2B indication, not so much indication for ablation. So what if patient have symptom? So if patient have symptom, then you need to localize the PVC is coming from what? From alveoli, from fascicular VT, or from the VT, because there is indication. So if patient have alveoli and the PVC coming for alveoli, the class 1 indication to refer for EP for ablation. And also we can, before that, we can start some patient with some beta blocker, calcium channel blocker, or flecainide. It's a class 2A indication. Another thing is fascicular VT. There is fascicular VT is another point that is this very sensitive to verapamil. The location, sometimes the ECG location, patient have some LBBB, and then it's responded well to the verapamil. So this patient is the fascicular VT. Sometimes you can start the compare when the medication of choice is verapamil compared to beta blocker. And also if patient don't have any features of ECG such features from the alveoli, fascicular PVC or VT, so you need to start medication first. You can start the beta blocker and then assess patient symptom, and then see if patient improve, then you can continue with the beta blocker. So this how you want to manage the patient with the idiopathic PVC. So this table show what is summaries of medication versus ablation in patient that have idiopathic PVC. So this table show, the first table is the ablation. The class 1 indication for ablation is patient the PVC coming from alveoli, fascicular PVC, and VT, and if patient have symptomatic and normal LV function. Because it's shown that with ablation have very successful rate of treatment, and patient can prevent this patient have some complication of PVC induced cardiomyopathy later. So same thing, if patient have in the apart from location from alveoli or fascicular VT, so there is class 2A indication for ablation, but you can start the patient with the beta blocker first, and then or calcium channel blocker first. This class 1 indication. Okay, so and then another thing in this table also, so if a PVC burden more than 20%, patient asymptomatic, normal LV function, there is class 2B indication or even for ablation. And also, how about amiodarone? Some patients, sometimes people say, what is the indication for amiodarone in PVC? That show that in the amiodarone is class 3 indication in PVC management. So I think we should avoid start patient with amiodarone. Okay, the first line still is beta blocker or calcium channel blocker. Okay, so this another thing, there's recommendation again for treatment for idiopathic PVC or VT. The class 1 indication is regular, like I mentioned just now, if PVC burden more than 10 with a normal ventricular function, so you need to monitor the PVC, monitor the LV ejection fraction. Okay, so the how frequent you need monitor, that is not mentioned, but I think in this patient have maybe, I think we can do maybe yearly echo, and then we see how's the patient symptom as well. If patient have symptom, and then maybe you can repeat again halter and also echo to look for progression of the disease. Sometimes it can progress, but less likely if the PVC less than 20%, sometimes very rare progress to PVC induced cardiomyopathy. Okay, so that's in another indication. The class 1 is also first line to treat the with refer for catheter ablation is the PVC coming from the alveoli or from the left side of vesicle. And also class 1 also beta blocker and calcium channel blocker is indicated in patient who have idiopathic VT PVC origin is other than alveoli or left vesicle. So the ESC 2020 guideline recommend that we need to refer for catheter ablation, but it's not in our center, because we have a lacking of the EP, we have lacking of the center and also do financial. So sometimes it's not difficult to achieve, but sometimes we can start always first line, start medication first, beta blocker or calcium channel blocker, depend on the location of PVC we suspect, and then reduce symptom. If still symptomatic, then we should refer to EP for ablation in the normal injection patient, unless this patient have already have some evidence of we suspect PVC induced cardiomyopathy. So this patient might be benefit to refer early for catheter ablation. Okay, so we just touch a little bit on PVC induced cardiomyopathy. So, like I mentioned just now, if PVC burden more than 20%, so this patient high risk to have the complication of cardiomyopathy or heart failure later. So this patient we need to treat aggressively, whether by catheter ablation. So how PVC induced cardiomyopathy, the pathogenesis is still uncertain. A lot of mechanism, a lot of what we call the thing that suggest. So sometimes this patient have some ventricular dyssynchrony. Okay, so some theory behind it. This is because of increase in oxygen demand or autonomic dysregulation or abnormal calcium handling. Because there sometimes we don't know why PVC induce cardiomyopathy, but as patient have so the study show that if patient have obesity, for example, if a PVC is more if PVC more than 20%, LBBB type of PVC, what QRM complex, have a short variable coupling, interval coupling, and interpolated, there is this patient is very high risk to develop PVC induced cardiomyopathy. So the guidelines show that if patient have PVC, high PVC, it already have some structural heart disease, the first line management is catheter ablation, because some center after we ablate the PVC and the successful ablate, the EF become normal, patient can recover. So that's important of management to refer early for catheter ablation. So this chart show that is a patient more than 10% with reduced or mildly reduced ejection fraction, no case of structural heart disease, LV dysfunction, LV. So if patient have no case of structural heart disease, and then we can see the any LV dysfunction. So if patient have a suspicious of coronary heart disease, valvular heart disease, or inflammatory heart disease, if there is none, so you need to consider doing the MRI to prove that this patient have maybe a scar VT, and we can from MRI we can detect any late cholesterol enhancement. If there is, and then we can say there is this patient most likely will have a structural heart disease aggravated by frequent PMC. So this patient is indicated to refer for catheter ablation. However, if no, so this patient have we just suspect that PVC induced cardiomyopathy. Also, there is more evidence, more indication to refer this patient for catheter ablation. Okay, so again, this is a recommendation for treatment for patient who have PVC induced cardiomyopathy. As we can see, the treatment guideline the first line guideline is a class 1 indication for refer for catheter ablation. Okay, and then all right. So okay, this I think there's another repetition of my talk just now. When you want to refer for catheter ablation, when you want to just start medical, just start medically first. Okay, so in summary for PVC, so if patient has asymptomatic normal structural heart disease, the PVC is less than 10, so sometimes we can just monitor, just reassurance patient. But if patient have any the indication to refer to start, is patient have symptomatic, and when to refer is patient have frequent PVC and also have some structural heart disease, LV is still infected, so refer for ablation. If patient have PVC burden more than 10, so you can still monitor this patient if patient have asymptomatic. So I think that's all my talk. So I just open up for any question. Okay, I think that's all.
Thanks a lot.
Okay, thank you.
Next